All right, we're at 12:15, so we will go ahead and get started today. Hi, everybody. Good afternoon. My name is Troy Jorgensen. I am the program manager for Project Echo Nevada. So glad you could all join us today on our COVID-19 update for this week. So I see a lot of new faces, so I want to give some background and some history about Echo and really kind of what we do. So Project Echo is a telehealth program that originated in New Mexico at the University of New Mexico in the early 2000s. And we adopted it here at the University of Nevada, Reno School of Medicine in 2012. And really our goal is connecting all of the great resources and providers, healthcare providers, mental health providers, everybody across the state of Nevada and even the Western region, and connecting you through video conference as we're doing right now to support you in your practices. So you're able to connect with, today we'll have our infectious disease physician, Dr. Krasner, pediatric infectious disease physician, Dr. Sarah Healy, and you can, pick their brains. You can ask them about specific patient-related questions, issues, and then each session also features a didactic presentation on a certain topic where you can claim CME or CEU credit for participating. So that's a little bit about Echo. Our sessions typically start off with introductions. So you'll get to meet our hub team and our experts for today. And then we'll open it up for questions or cases. As I mentioned, really our goal is supporting you with patient care and any patient-related questions or issues that you have. And then we'll get into the didactic presentation, as I mentioned. So Dr. Krasner, if you could introduce yourself, please.
Hi, I'm Charlie Krasner, and I work for the medical school in Reno, and I also work at the Veterans Administration Hospital here in Reno as an infectious disease consultant.
Thanks, Dr. Krasner. Dr. Siddiqui.
Hi, I'm Dr. Siddiqui. I'm a pulmonary critical care physician at the Reno VA Medical Center.
Thanks, Dr. Siddiqui. And Jessica?
Hi, I'm Jessica Thompson. I'm one of the infectious diseases pharmacists at Renown.
Jessica, and then I'll find Dr. Sarah Healy. And Dr. Healy, please go ahead.
Hi, I'm Sarah Healy. I'm a pediatric infectious diseases provider at Renown.
Thanks, Dr. Healy. And then Sneha, could you introduce yourself as well, please?
Hi, this is Sneha Sharma. I'm the program coordinator for Project Echo Nevada.
Thanks, Sneha. All right, so again, welcome everybody. Thanks for joining us today. A large group, so if you could actually write in your name and your location through the chat box for us to have an attendance record of today's session, that would be greatly appreciated. So like I said, really our goal is supporting you with patient care and patient-related questions. And we're so grateful to have pediatric infectious disease physician, Dr. Sarah Healy on today. So I'd like to open it up. I know we have a number of school nurses on today as well. So does anybody have any specific questions for Dr. Healy or the rest of the team, Dr. Siddiqui or Dr. Krasner? I've limited everybody's ability to unmute yourselves. So if you can actually just write in your questions through the chat box, that's how we'll do everything today. So any specific questions, patient cases that you want to run by the team, please write those in through the chat box.
So, Troy, we're going to give a big block of time so Sarah can talk about this new syndrome and then any other kind of questions, about returning to school, and hopefully give us a lot of information on that during the talk. So that might be a good time for those kind of questions.
Okay, certainly. I do see some questions coming in here. So what type of rash is seen with the pediatric inflammatory syndrome?
So I'll give a presentation today that will show some of the rashes that have been reported across Europe and coming out of the East Coast. They have been variable, similar to the rashes that we see with Kawasaki disease as well. Also with staph scalded skin or toxic shock or MAS. So there is some variation in them. They're usually macular, papular. Some of them are quite impressive that have been reported coming out of Italy and also from the New York area. So I'll show some photos of that today.
Sarah, you want to just start off and give your discussion, and then we can do our other slides later if you'd like to do that. It might be nice.
Okay. Yeah, I'd be more than happy to do that.
Okay.
All right, let me get to those then, and we can get started here. All right, so just some real quick housekeeping items, just letting you know that we do record all of these sessions. If you don't want to be on the video recording, let us know and we can actually edit you out of anything that we post. And then if you do present a specific patient-related case, please just don't share any protected health information. We just want to avoid any HIPAA violations here today. So Dr. Krauser, should I skip ahead to Dr. Healy's portion?
Yeah, why don't you just let her take over and we can do my other stuff, whatever time's left. Since we got her here.
Do you want me to just go ahead and share my screen?
Yeah, why don't you go ahead and put your stuff on.
All right, just a second here. All right, Dr. Healy, you can go ahead and share your screen now then.
All righty. All right, can everyone see the slides?
Yeah.
Okay, great. Thank you for letting me come and present this information. It's in a.
Sorry, Dr. Healy, we just lost the slides. We don't see them now.
Let's try this again. It says host disabled participant screen sharing.
All right, let me turn that on again and then we'll see if that works. So give it a shot now.
All right, can you see him again?
Yep.
Okay.
Yeah, perfect.
Great. So just as this is evolving over the last couple of weeks, they have given it quite a long name, a pediatric COVID-associated multisystem inflammatory syndrome. For those who aren't pediatricians, because a lot of the news you'll hear about this being Kawasaki-like disease, the majority of pediatricians, this is one of the first things you learn in residency, to be on I4 and why we watch fevers and durations of fevers very closely. It's a spectrum of symptoms and laboratory findings that was initially described by Dr. Kawasaki back in 1967. Is usually an acute onset of systemic vasculitis. Let's see if I can move that. Of medium-sized vessels, and typically it affects mostly infants and toddlers, which is a real key point to highlight here, because as you'll see with this COVID-associated inflammatory disorder, this is a different age group we're seeing these symptoms present in. Kawasaki disease, there's been a lot of research into it. The etiology is actually unknown. We do see it come in spurts, so you'll see it a season of Kawasaki disease presentations. It'll be different in each region across the United States. There is a belief that there is a genetic variant, as there's a higher case report in Southeast Asia, and they've also identified some genes that might predispose individuals to this. Related to the genetic variants is that there's probably an infectious trigger. Now, is that the same infectious trigger in each child is unclear. There is some data that came out of the group in Chicago that does quite a lot of Kawasaki disease research that was looking at a newly identified RNA virus, but causality has not been, or even true association has not been defined. They know that there's in animal models, there's an activation of the innate immune cells, IL-1B, IL-6, and TNF-alpha, so similar things that we've seen with COVID. And really, why do we care about this disease process is because a delayed diagnosis, we know if we do not initiate treatment early, that almost about a quarter of these individuals, children, will have coronary artery aneurysms. And this has now become the most common cause of acquired heart disease in developed countries. We'll go through the spectrum of clinical symptoms and laboratory findings, but really we look for this conjunctivitis, the red cracked lips, or beefy strawberry-like tongue, diffuse rash, in particular looking at the hands and swelling of the hands and feet, lymphadenopathy, which there's defined measurements, and that's showing here in the ultrasound some of the measurements of the lymphadenopathy. Again, you can see the rashes on the bottom of the the feet and also on the abdomen. And then late findings are this peeling that you can see around the fingertips, and then also these bow lines that appear on the nail beds. Similar to a lot of a pediatric infectious disease, the Red Book is kind of our resource to evaluate. And interestingly, even though Kawasaki disease really is a vasculitis that's handled mostly by cardiology and rheumatology, infectious disease providers, depend on where you're at, are often involved because there's a sense of needing to rule out other etiologies before classifying it in this kind of triad of clinical symptoms and laboratory findings. So the key kind of linking is looking at fever greater than 5 days, and then 2 or 3 of the compatible clinical criteria that we looked at, the conjunctivitis, lymphadenopathy, rash, cracked lips, and the swelling of the hands. And then with infants, if we get to greater than 7 days without other explanation, folks start thinking about it even without the clinical criteria, because we know this population are at increased risk for bad outcomes. In the process, then we look at assessing laboratory test results. We look at inflammatory markers that get us down to a pathway of either evaluating additional laboratory markers such as your CBC with differential, LFTs, looking at your UA, and then triggering to get an echocardiogram and whether or not you treat. As you can see, there's an acute and a subacute phase, and really we're trying to catch it, and there's this magical line of 10 days to initiate treatment. Some of the kids present late, unfortunately, and we'll see them with the coronary artery aneurysms already or dilatation. But really starting at about 5 to 7 days up to that 10-day mark, you'll see pediatricians start to very closely evaluate for this so that we can initiate treatment early, which is IVIG and aspirin. The consequences of not treating early, or even in those who have presented during that time but have high risk factors such as our younger children, on echo, they'll see these coronary aneurysms develop, and that's what we're really trying to prevent by treating early. So treatment for Kawasaki is IVIG. It's a high dose of 2 grams per kilogram. We also do high dose aspirin. There's some new studies looking at moderate dose aspirin, and then taper to a lower dose once they're afebrile. The 10 days is the studies that originally looked at IVIG and looked out at outcomes was really that you needed to initiate IVIG before you got to your 10th day of fever to reduce the risk of development of coronary aneurysms. And you can see a significant decrease from 25% to 5%. There are about 1/3 of Kawasaki patients who don't fully respond to these measures. And this is when we hospitalize these kids and give them IVIG and high dose aspirin, we'll watch them closely for the next 48 to 72 hours to see if they have a fever that recurs. Oftentimes they'll either get another dose of IVIG, they may get corticosteroids, and some of the more difficult cases might get TNF blocking, IL blocking agents as well. That's been a little bit variable from pediatric hospital to pediatric hospital, depending on your cardiologist and your rheumatologist. There are other entities within this Kawasaki disease type spectrum. There's incomplete or atypical. Those are the ones not meeting the classic Kawasaki criteria to get you down the pathway for IVIG administration. This often occurs with the younger children, so the under the 2 years of age. And then there's this unique presentation of Kawasaki shock syndrome, where you have significant thrombocytopenia. Essentially, they look like they're in DIC and septic shock without a bacterial etiology, which is a really kind of key point to point out because you'll see this with the COVID inflammatory syndrome. So as many know and have seen in the news and also through the publications that are now coming through across the world, COVID-19 in children has been relatively mild. In the most recent CDC report, if we look at approximately the 150,000 reported cases in which we know the age of presentation only 1.7% were children aged less than 18 years of age. And if you consider that children under 18 years of age account for 22% of the US population, it's a significant, they're impacted significantly less than our adult population. In addition, the median age has been 11 years. You've probably seen in the publications that those under a year of age might have some increased hospitalization. You can see this is holding true when we look at the CDC bar graph, where you see here in black is those who are not hospitalized in proportion, those who are hospitalized, and then those who receive ICU care. I will say we've had 2 children admitted to Renown Regional Medical Center. Our first one was 2 months of age and really barely met criteria for admission. They required some supplemental oxygen in the ER and were subsequently admitted just really for monitoring of their cultures to make sure that there was no co-infection with a bacterial pathogen. But they remained on room air throughout hospitalization or discharged home. So I think a lot of people are having a caution in this young age group to just make sure that they're stable before we send them back out. Our other patient was in this 15 to 17-year-old age group and required hospitalization secondary to supplemental oxygen, also due to multiple underlying comorbidities that would put them at an increased risk for poor outcome. So you can see as discussed, the hospitalization rates are low, the ICU rates are low. Most children are either asymptomatic or exhibit mild symptoms. So most of these pediatric patients who are being diagnosed are outpatients. They're usually being diagnosed as a part of an outbreak investigation of a family or within one of our group homes or inpatient psych facilities or juvenile detention centers. That really we have few being admitted and requiring ICU care. That's not saying it's not happening. So there is a nation, well, not even nation, North America-wide network of pediatric ICUs who have been posting since the start of the pandemic in the United States and in Canada about their admission rates to their pediatric ICUs. This gets updated every day. And actually over the last month and weeks, probably similar to what we saw with the adult population, you could see this marching across the United States with most of the hospitalizations and ICU admissions really occurring in the East Coast. The thing to highlight is you'll see here over in the pie chart, the age distributions. And the first thing to highlight is the greater than 30 years of age and 18 to less than 30 years of age, as these are not our typical pediatric ICU admissions. But as many know, in the East Coast, as the adult ICUs were becoming overwhelmed, the pediatric ICUs started taking otherwise healthy adults into their ICU for care. Any questions, I guess, before I go into the COVID presentation?
Thanks, Dr. Healy. Yeah, any questions, please feel free to write those through the chat box.
I'm trying to open the chat box.
Go ahead, Dr. Healy. I'll interrupt you if anything comes in.
Okay. So in the news coming out, first it came out of the UK and then the East Coast as well started reporting what has now been named pediatric multisystem inflammatory syndrome. And then if it's in the US, it ends there, but the UK has put on temporarily associated with SARS-CoV-2. So PMIS, and then whether or not you do TS, and the end depends on if you're in Europe or if you're in the US. It's believed to be antibody or immune mediated. The kids are presenting with fevers, diffuse inflammation, either single or multi-organ failure. And really that's been unusual is the predominance of abdominal symptoms, and then some characteristic lab findings. It's similar in presentation. You can see in these photos, this is a child from Italy. This is a child that was posted in a New York presentation, is you get this kind of intense, really beefy red type rash that I think of more in kind of toxic shock or macrophage activation syndrome than the kind of more lacy, diffuse rash that we would see with Kawasaki disease, though you can see this with Kawasaki as well. Laboratory-wise, how it differs a little bit from Kawasaki disease is you'll see a predominance of lymphopenia, some neutrophilia, and then similar, you'll see an elevated CRP. The key thing that people have brought this out to attention is these children will initially present not that toxic and just with fever and some abdominal pain, but will quickly go on to develop shock or multi-organ dysfunction. They've looked at testing these children for SARS-CoV-2 by PCR, so the classic nasopharyngeal or bronchial wash. And most, I would say, are testing negative, which would go with this being an antibody or immune mediated. And so then they have gone back and tested those who have tested by diagnostics negative for serology, and the majority of those have been positive, either for IgG alone or IgG-IgM. The group out of Italy did a nice comparison looking at the differences in those who might have been diagnosed with Kawasaki disease prior to the pandemic, and then those who had presented with this PMI-STS syndrome. And as you can see, is the age of onset is quite different. For Kawasaki disease, we would see younger children, so the toddler age, going into preschool. The kids who are presenting with this COVID-associated multisystem inflammatory disorder are older. Their median was a 7.5, but we've seen reported 8 to 11 years of age. And it is interesting that it's not really been that many reports out of Southeast Asia countries. This really kind of came to light through the European countries and then the East Coast. Because of this, there is some thoughts about the isolate that went through Europe and then came through the East Coast. Maybe there was a mutation associated with that, and why the West Coast and Southeast Asia was not seeing as many of these children present. That still needs to be hashed out, whether that's a true relationship or a theoretical kind of a hypothesis at this time. You can see again that we discussed about the lymphocytes significantly decreased in the COVID-associated inflammatory disorder. And typically in Kawasaki, we'll see a thrombocytosis, especially towards the end of 7 to 10 days of fever. And we're seeing a thrombocytopenia in the inflammatory disorder associated with COVID. I will admit a lot of the Kawasaki kids we do not get a ferritin on, so how much data is going into this one, but you see a significant increase in the ferritin. And really these definitions of looking like macrophage activation syndrome or Kawasaki or Kawasaki shock syndrome, we see a lot more of those kids presenting in this COVID inflammatory disorder in those states. They also are having a significantly higher rate of abnormal echocardiograms, and a lot more are resulting to get steroid treatment in addition to their IVIG. So as you can see, they are a lot, even though the news has promoted it more as a Kawasaki like syndrome, they are more similar to toxic shock or macrophage activation syndrome. And really a concern is the degree of cardiac findings, myocarditis, cardiac dysfunction, coronary complications. Interestingly, if you look back in some of the old papers looking at what is the etiology of Kawasaki disease, there are some publications out of Japan looking at other human coronaviruses, and there's mixed results about association in those studies. Some show no association. Some show an association for one of the coronaviruses, but not other human coronaviruses. And so I have a feeling there'll be a lot more research looking into this. It's also a matter of how they look at the association, whether they're looking at antibody results or looking at diagnostic results at the time of diagnosis of Kawasaki disease. So the group from the UK has been really kind of leading the forefront of defining this syndrome, and has set up 2 registries to collect information from hospitals worldwide. They are promoting some clinical, laboratory, and imaging criteria, and that they would like to collect information about. You'll see some common overlap with Kawasaki disease, also with some toxic shock criteria, as well as macrophage activation. So looking again for persistent fevers. What's unique is usually an oxygen requirement, hypotension, which often we will not see with Kawasaki disease, but may see with macrophage activation syndrome or toxic shock. And really kind of the key symptom that's unusual for the syndrome is the predominance of a reported abdominal pain or serositis. Also looking for similar Kawasaki, which is the mucous membrane changes, lymphadenopathy, swollen hands and feet. Laboratory findings are similar to labs we would get for toxic shock or for macrophage activation. Really looking and ruling out other etiologies, looking at CRP, D-dimers, high ferritin. These are labs you're also seeing that we're getting on the adult side to look at the cytokine storm associated with coronavirus as well, and following over time to see if they're looking like they're going to go into increased risk for cytokine storm, and there should be an intervention. There's other labs such as IL-6, which has been discussed a lot with COVID-19, and looking at triglycerides, LDH, and thrombocytopenia. I think the key thing that's been coming out is for these kids that we have a suspicion for this, but are monitoring because they're looking fairly well, is that if you get an echo or EKG early and everything looks reassuring, to not drop your guard on that. There's been reports that kids change quite quickly within a day or a couple of days. So to work closely with our pediatric cardiologist in evaluating these kids early and perhaps frequently. So their current recommendations, and I'm sure these will evolve as more cases come through. I know in the pediatric listservs, there different groups are reporting individual cases now and trying to accumulate them into the database. Really is the close monitoring. The deterioration can be rapid, early EKG and echo, and that we're still doing the initial early treatment with IVIG plus aspirin, and then looking at immunomodulating drugs as well. So that's kind of the summary I was able to pull today.
That was good.
Excellent. Yeah, thank you so much, Dr. Healy. So we'll take a few minutes for Dr. Healy to answer some questions, and then Dr. Krasner has a brief presentation for us as well. So one question that came in a little earlier was, are there any specific symptoms to look for when excluding children when our child care center opens?
So that's a difficult question because most of the kids are mildly symptomatic and a lot of them may be asymptomatic. So we still follow the CDC guidance of how to screen the children at the hospital. We're still looking for unexplained fever, cough, shortness of breath. We do recognize though with the literature that's coming out, that's not necessarily the same presentation for children. But currently that's what we've been using to evaluate who to test. I think as more information comes through from across the world about how children present, we may be adjusting that. And some of it we may not, until we have universal testing, we may not be able to adjust to that because these kids are so mildly symptomatic that it may be difficult to know if they have a cold or if this is COVID-19. The literature that has been coming out has surprisingly showed, because I usually think of kids as the spreaders of most disease, that they're the transmitters throughout our community, that when they look at family cohorts, it's not looking like the child is the transmitter within their family in some of the smaller studies that have come out so far. But I think we need more data to know that for certain.
Thanks for the question. So I've turned on the option now, if you do have a question, that you can just unmute yourselves through Zoom. So use the little microphone icon in the lower left corner, or *6 if you're joined on telephone. And also feel free to use that chat box still as well. So a question from Dr. Siddiqui.
I can answer. I can ask that. So, Sarah, this is Faisal Siddiqui, pulmonary critical care. So the table that you presented comparing the two groups,
Yep.
KDCC was n equals 0 in the first group. I thought that was the Kawasaki syndrome patients, right?
It was, but they had none presenting in the shock syndrome.
Okay,
So yeah.
So they did not have a very huge inflammatory response, and that's probably would be a reason why they were a little different from this TPMS MS
Yeah.
syndrome, and that probably would be more similar to what we see in these patients in COVID.
Correct, and they had another nice figure that I thought about putting in there, and it looks at their ER admissions over time, and then looks at their rate, because all these kids essentially got classified as Kawasaki disease before they recognized the syndrome with COVID-19 and how they're going to reclassify them. And so they were looking at their rate of Kawasaki over time before the pandemic, and then they looked at their ER, which saw the huge spike when they had all the adults coming in and getting admitted. And then you can see this tail end where their admissions were decreasing, and that's when these kids started to pop up. And so it was really a leg behind. But I agree with you, since they didn't have anyone with Kawasaki disease with the shock syndrome, which look different from their typical Kawasaki, it would explain some of their differences seen.
Thanks, Dr. Siddiqui, for your question. Any other questions before we move on to Dr. Krasner's portion of the session today?
So, Sarah, what do you think about kids returning to school at this point?
That's a tough, loaded question.
Yes.
The school question is really difficult because it's beyond disease transmission. It's what kids get at school too. In terms of kids, that's where they get fed. That's where they get their services. What's the better of the two kind of balances? A lot of European schools are opening back to kids. And so I think we're going to see how that works and how social distancing works with 4-year-olds, with 5-year-olds. I mean, I applaud them for trying to keep a 5-year-old away from another 5-year-old when you see them like standing in boxes. I don't have a good answer for that one. I think other countries are going to try it, and we're probably going to learn from it and how to do it properly. But I do worry about kids not being in school for other reasons that are unrelated to the infection, because of all the benefits they get from being in school. So that's me not answering the question.
But even if they get a mild case, they may not be that contagious if they come home, you're saying too, right?
That's the current belief, but those are very small studies and in very small family cohorts. And so I'm a little bit, that's the initial data coming out. I'm hesitant to say that will hold true. I do worry about household clusters and those kids, potentially still transmitting back home. Hopefully by the fall, we will have more information to make an informed, I think, decision about returning to school.
Thanks, Dr. Healy. All right, so Dr. Krasner, I'll pull up your presentation here and we will go through that, and then we'll have some more time at the end for questions.
Thank you so much, Dr. Healy. That was great. Really interesting. Appreciate it. So I just want to I'll point out a few things. So this is, every week we try to look at what's going on here in Nevada. And one of the goals we talked about last week for Opening Nevada was that less than 10% of the cumulative number of people tested, which is 66,000, less than 10% of them should have positive tests. For example, like in Fairfax, Virginia, they have an outbreak, and 25% of their tests are positive. So we finally passed where this is about 2% of the Nevada population, and now the positives, if you look at the next slide, 6,300 is now we've finally broken through that 10% barrier. So if you look over here, the World Health Organization, one of the markers, they say that we want the cumulative number of testing, that less than 10% of them should be positive. And so we were up about 12% last month, 13%. But now that we're dropping below 10%, and I think it's down to like at 5 or 6%, no, because you want to, if you have more than 10% are positive, it suggests that you're not testing enough people. But now that, even though we're expanding the number of testing, the percentage is going down. So this is one of the first markers that we passed, which is a nice sign. One of the other markers that they want on the other side of the slide is that we want to see a decrease in the number of hospitalizations. And so this is the confirmed cases of COVID. These are the rule out ones. Seems to be on a downhill slope in Nevada, which is very encouraging. And so with that's going, we've had at least 2 weeks now of a decreasing number of patients, both suspected and infected with COVID. There was a little bump here, but the trend is down. And if you look on patients in the hospital and intensive care unit, we also have a down slope. These are patients in the ICU, which is the light blue, and these are patients on respirators. So we have some good signs that the social distancing that we've been doing for the last 6 weeks or 4 to 6 weeks has at least effectively controlled the spread, and we haven't had that massive second surge. Even though now, with what we've seen with Mother's Day, we'll see what happens. So next slide, please. And this is our death rate in Nevada. 1 death is too much, but fortunately we're going in the right direction. If you go back to the middle of April, it seems like we're averaging about 5 to 8 or 9 deaths a day reported in Nevada. And now we've seen that it's definitely the last 2 weeks, going up to May 13th, we've had a significant decrease in going in the right direction. So the social quarantine that we've had going on seems to have reduced the number of deaths, number of infections, and the number of hospitalizations. So that's been very nice.
Dr. Krasner, one question here for you, and then a couple for Dr. Healy. So is there any concern that the bump in cases in the last 3 days is related to reopening or relaxed social isolation?
Well, you got to be concerned. It doesn't take more than a few days to become viremic, but usually before people get symptomatic, it's usually at least 5 days before they have the onset of their symptoms, and another 5 to 10 days before they get sick enough to go to the hospital. So it's not clear that is the cause. But if you go to Walmart or Home Depot these days, it's rare to see somebody wearing a mask, and it's very crowded. So it seems very reasonable to think that we're going to see a bump in the next week or two. It's become a political issue.
Dr. Healy, a couple questions for you. I'll unmute you here just a second. So do you feel that regular surgical masks or homemade masks are sufficient in an outpatient peds setting with proper screening questions and temperature checks?
So I know each practice is kind of adapting of how to bring kids back into clinic, including also sick visits as well. We had discussions this morning that there's a concern about vaccine rates dropping, and to make sure that it's a safe environment for these kids to be able to come back and that their parents feel comfortable coming back into the clinics. At the hospital, we wear N95s everywhere. I think a surgical mask, and Charlie definitely chime in, would be fine in an outpatient ped setting. The homemade masks, I would have to look at the recent CDC recommendations on that. I honestly haven't looked recently if they are part of the recommendation for outpatient clinics. Charlie, do you know?
Yes, they are. I mean, basically you just want to physically block if somebody's coughing, you want something to block it. It's probably at least almost as efficacious as a surgical mask in the outpatient setting. You wouldn't want to use it in the hospital, but we're just trying to physically block them. Those droplets coming out of the person's mouth, and so it's probably a reasonable. If it covers up to the nose and goes down for enough, I think it's a good step.
Yeah.
Okay. Another question here. If a child has had KD, any other autoimmune disorder, if a vaccine comes out, would you recommend these children get the vaccine?
That's a really great question. And I think that's a part of building into, why some reports are, why can't we get a vaccine quicker? And so we need to look at these kind of longer consequences. We don't know exactly, is it the virus itself? Is it a protein? So it will be how the vaccine is also designed. Is it an RNA vaccine? Is it a subunit vaccine? Is it a killed version of the of SARS-CoV-2? These questions have come up also when people have looked at challenge models with a weakened version of SARS-CoV-2. So I don't have a great answer for that. It'll depend on what the vaccine construct is and what the concern should be associated with it.
Thanks for the questions, everybody. We'll keep moving here with Dr. Krasner's presentation. I know we're getting close to the top of the hour, almost 1 o'clock now. So if you do need to take off, we completely understand that. I will send out the link to the website for our Antibiotic Stewardship Echo webpage. And on there, you'll find the upcoming dates. So we're going to be here every week, every Thursday at 12:15 on the Zoom channel here. And then you'll also find the link to the slides from today, as well as the link to complete the evaluation to claim CME or CEU credit. So yeah, if you have to take off at 1 o'clock, we totally understand, but we hope you'll join us again next week. So Dr. Krasner, we'll keep moving here.
Troy, I'll hold off on a lot of this for next week, but the one thing I would want is Jessica Thompson to give us an update on the remdesivir debacle. And, if somebody's in Elko or Winnemucca, how they can get remdesivir. So I'll turn it over to Jessica right now.
So this whole list business ended up not being the case for Nevada. The state of Nevada, of the 1.5 million doses that Gilead had, 400 of those doses were given to the state of Nevada to disperse throughout the state. From my understanding, the allocation was based on the number of ICU beds and whether or not you had qualifying patients. And so we went through Dave Weiss with the State Board of Pharmacy, who was in charge of that allocation, from my understanding. So if you have a patient that meets the EUA criteria and you have ICU beds, I strongly recommend that you reach out to him to get information on how to get remdesivir. Unfortunately, again, 44 vials for the state of Nevada doesn't go very far. Here at Renown, we were allocated 44 vials, which is enough to treat 4 patients. So not nearly as many as that we have currently hospitalized. So then we don't know if and when the state of Nevada will be getting more remdesivir. But the majority of hospital pharmacies have been on the weekly call with the State Board of Pharmacy and should be aware of who they should reach out to if you do have a case. So I strongly encourage you reaching out to your pharmacy department or whoever provides pharmacy services for your facility, and then contacting the State Board, specifically Dave Weiss, if you have a patient that would qualify for remdesivir.
But outside of that, they have this special thing if a woman's pregnant or if it's a child, they can get it, right, without having to do this.
Yes, so that the compassionate use, which you would apply through Gilead and the FDA, still applies for pregnancy and pediatric patients. The exclusion is really initiating therapy in somebody with a creatinine clearance less than 30 or an ALT 5 times the upper limit of normal.
Okay. And actually, they're still waiting for the actual report that was released on that. People don't have that data. Well, why did they release this medicine? What was the thing that the committee said we should make this available to actually get an idea where we should be using these in what patients too, which I think is a frustration.
Yeah, we're flying blind. I mean, we determining who should get the drug when we have 4 courses essentially, without actually seeing the study and if there was maybe a benefit administering it earlier versus later. So I think each facility is going to have to make their own determination until that data is available.
Yes. So before we go, somebody just asked about the Abbott test. I actually have this Abbott 1 test that is that 5 to 10 minute test. and everybody thought it'd be great because you just do a nasal swab and then you put in the little Abbott one machine. NYU just came out with a study where they compared PCR results, like from a Cepheid machine, versus that, and they only had a 50% positivity rate in the ones that we knew were positive. And that's the same one that President Trump uses in his office to check people daily. And so he had one patient, one of the workers went from negative to positive. So it's not, at this point, it's not a reliable test. They apparently had approved it that you could use it with a swab or put the swab in viral medium, but the company says don't put it in the viral medium. You have to use the swab itself. But that Abbott test, it seems like if it's positive, it's helpful. If it's negative, it doesn't mean anything. But we can talk more about some of these new tests that are coming out. And the other thing is I wanted to mention, we've been talking about the serologic test, and LabCorp has now is using the Roche and the Abbott serology test, which has like a 99.9% sensitivity and specificity. So if you want to have somebody test as they've been exposed, that LabCorp is a good way to go. The only other issue with the antibody testing is that it seems that the sicker you were, the higher your antibody titers are probably. So if somebody had a mild disease and they're positive, they may not have, we don't know, neutralizing antibodies to prevent an infection. So that's still not known. So we don't really know what a positive antibody test in somebody who's asymptomatic or mildly symptomatic, if it really actually provides them protection. But it will, those tests can now, you can reliably say whether or not you were actually exposed at some point. And so we'll talk about all the other, I have some other interesting slides, so we can do it next time.
Okay, there was a question about mask usage and if someone is not trained can actually be more susceptible to getting the virus. So I want to pull up your slide about masks here, Dr. Krasner, and if you can talk about that a little bit.
And this was how important masks are to protect others, and doesn't have to be an N95 or a regular mask or just a cloth mask. But if you look at somebody who's talking to you, and if you go to Japan, has all these amazing videos on YouTube, but somebody just talking here, exhaling, the aerosols carrying the virus go out to about 3 feet. If you have just a little cough, it goes out to about 6 feet. But they have some, if you sneeze, there's some amazing videos showing that the droplets can go out to about 20, 25 feet. So it's extremely important. Not just talking alone is enough to send out the infectious particles. And so they look at the probability of somebody becoming contagious. If somebody is spewing the virus just by talking and neither of them has a mask, it's very high. If you're wearing a mask, but somebody's not wearing a mask and they're contagious, you still have a pretty good chance of being infected because you're going to inhale around the edges of the mask. If that person is wearing a mask who's infectious, it reduces it significantly. But if you're not wearing a mask, you still can get infected. And really the only way that it works, if somebody's wearing a mask and you're wearing a mask. So it's really important to wear a mask. And so if you're wearing a mask and somebody at Walmart thinks it's his right not to wear a mask, you still have a significant chance of getting infected. So you have to feel that just wearing a mask is not enough to protect yourself, but it probably doesn't matter whether it's a surgical mask or a cloth mask if you can block that exhalation.
All right. Some more questions here about the Abbott IgG testing.
Yes.
Is there any concern about cross-reactivity of the Abbott antibody test with other non-COVID coronaviruses?
It looks like it's a very specific test, and they feel pretty comfortable. They've done looking at that. It is quite specific for the coronavirus. They feel almost 100%, 99.8 or something percent specific and 100% sensitive for picking up antibodies after about 14 days. And that's the Abbott and the Roche are basically interchangeable in terms of efficacy. But again, it's giving you a positive or negative. It's not giving you a quantitative antibody load, which may correlate better with immunity than just having a positive or negative test. But they're going to be doing that, throughout Washoe to try to do a community-wide serologic test to be organized by Dr. Pandori and the Nevada Health Department. They're starting that up pretty shortly.
All right. Any other questions out there that we can answer for you today? Please feel free to unmute yourselves with the microphone icon on the Zoom toolbar, or you can write in through the chat box.
How about just for fun, show me, go to my last slide and show the video. This is a 30-second video you may have seen on the internet. And this is said from somebody who's a fan of, this is a video where they had 10 people, they put some fluorescent thing on this guy's hand, and they had 10 of them go to a buffet. And then they turn, after 30 minutes, everybody had it on their hands and some had it on their face, and they're all over their utensils and everything. So this was just one person at the buffet bar doing it. So if you imagine 50 people touching that handle, you're probably being exposed to germs of 50 people. And I love the Atlantis buffet, but I think I'll hold off if they set it up again. All right, thank you all.
Yeah, thanks everybody. So there's a question about seeing a cough diagram again. So what I'll do actually is just send the link to our website, and we'll take a look at that actually real quick here, where you can access and download the slides from today. So this is our Project Echo Antibiotic Stewardship website. I just sent out the link through the chat box there. So you find everything you'll need on here. So we've got a case review form. So if you have any specific cases that you want reviewed by our team, go ahead and click that and submit those to us. And then if you scroll down, you will find everything from today's presentation. So this link here is the link to the slides. And then the link here is to the CME or CEU credit claim form. So that should take care of everything that you need in terms of this session today. So yeah, this was great participation today, everybody. Thank you so much for joining us. So this is our weekly COVID-19 Echo. So every Thursday at 12:15, you can sign on with us through Zoom, and we will be here to support you. So hope to see you all again. Don't forget to claim that credit if you need to. And yeah, take care, everybody. Thank you. Bye-bye.